All right. Hello, everybody. My name is Dr. Vidit Bhargav. I'm an assistant professor in pediatric critical care medicine at University of Alabama in Birmingham, and I want to walk you all through point of care lung ultrasound. This is only an introductory talk to point of care lung ultrasound, and there are lots of things that could be added to this talk. So let's begin here, and then in subsequent talks, we will build upon this. Before we do get started, though, I want to take a second to thank Dr. Prabhakaran and PCCIRLS group for giving me this opportunity to talk to all of you. So thank you so much for that. One big thing that I always talk about when I talk about point of care ultrasound is that it is not a replacement for formal imaging. Generally, the scope of POCUS, especially in developed countries like US, is limited and it's restricted to providing additional information in real time. We do not use it as a substitute for radiology, and I would recommend the same for all of you who are learning this as a new skill. These are our objectives that we will try to get through today's presentation. We will talk about why you should do lung ultrasound, what is the right kind of probe to use for this, how do you acquire images, what is the concept of different lung zones, what are lung artifacts, and then finally we will go through some normal lung ultrasound findings and some abnormal ones. So big picture wise, I try to break down the indications of lung ultrasound into three broad categories: basic, intermediate, and advanced. Basic indications are all those things that are quite easy to learn with the ultrasound. The learning curve is pretty rapid, and there is a rich body of evidence that supports the inclusion of this skill for patient care. The intermediate ones are the techniques which have also strong evidence in literature, but maybe there is a little bit of a learning curve before one becomes comfortable with that. And then finally, the advanced indications are ones which may be appropriate for a few patients in certain settings, but may not be useful as a widely disseminated tools. And so we will at least try to get through the basic and the intermediate indications of lung ultrasound in this talk. And if anyone is interested in the more advanced functions, then I would recommend either looking up the literature on the subject or reaching out to me or one of my colleagues, and we can try to walk you through these. The basic principles in lung ultrasound are that normally the lungs are filled with air when they're healthy. When the lung becomes diseased, it becomes consolidated and more tissue-like. But why is this important? It's important because when the ultrasound was being used for other organs, in around 80s it was thought that it was a useless tool for lung ultrasound because air is a good reflector of sound and a bad conductor. Especially healthy lung, what it means for it is that it's almost impossible to see anything inside a healthy lung with the exception of the pleura. But this is where it gets really interesting, because as the lung becomes diseased, it becomes consolidated and tissue-like. It's easier for the ultrasound to transmit through that diseased tissue and create these artifacts which we interpret to diagnose different pathology. Due to the almost total reflection in healthy lung and the pleura, it appears hyperechoic, which is an ultrasound term for being bright white. On the other hand, when the lung tissue is diseased, the sound, as we talked about, can pass through, and it either appears black in color if it passes through fluid, or if it passes through the tissue, it appears in different shades of gray. If anyone is interested in explanation of why there are those different shades of gray, please reach out to me, but I think for this lecture it is a little outside our scope. And to conclude the basic principles, whenever there is discontinuation of air in the lungs due to fluid or consolidation, it leads to better transmission. This produces artifacts that we ultimately interpret to diagnose what pathology may be seen in the lung picture. In terms of probe selection, generally what I use in my practice are the linear probe and the curvilinear probe. The benefit to using a linear probe is that it is a very high resolution probe. So if I do not have to scan a patient that has a thick chest wall or is older, such as a young infant or a neonate, then it gives me really high resolution imaging, which increases my diagnostic accuracy. However, if I have a child that is a grown-up child, such as a teenager, I prefer to use a curvilinear probe or an abdominal probe because it has just such a big, wide sector that it can cover large areas of the lung. And we know lung is one of the larger organs in the body, so in able to diagnose things more effectively, it is better to scan as much of the lung as possible. However, that being said, whatever probe you have with you is the best probe for doing any kind of ultrasound. So even if you did not have one of these probes, I would not worry about it and just proceed with the kind of probe you have. In terms of the probe placement, various places in the literature talk about the concept of different lung zones. So what all these concepts mean is that they try to divide the chest into two parts, right and left. And then they divide each of those sides into multiple areas so that there is a systematic approach to scanning. Because so many different lung zones and practices have been described in literature, I did not include any of those since not one is better than the other. But the most important thing to remember is to cover as much area of the lung as possible. So with that, let's look at this image on the left here. So for fluid, the fluid settles down at the bottom, and so you place the probe in the mid-axillary to anterior axillary line for the right side and mid-axillary to posterior axillary line for the left. And this will allow you to see your right and left upper quadrant. The probe is placed in a sagittal plane, and then the probe marker is oriented towards the patient head. In terms of a pneumothorax or the air, it rises to the top, so you're scanning as high in the chest as possible, generally in the area of first to second intercostal space. And again, the probe marker is towards the patient's head, and the scanning is done in a sagittal plane. I practice mostly in the pediatric ICU, and so most of my patients are sick enough where they're laying on their back. So I generally just scan the anterior and the lateral areas of the chest, but there is definitely literature which suggests that if you scan the back as well, it increases your diagnostic accuracy. So please keep that in mind. And as I mentioned, lung ultrasound is a study of artifacts. So I do want to discuss one of the artifacts that is very relevant to lung ultrasound and is the basis for why we do what we do here. So this artifact is called as a reverberation artifact. So what happens, as we talk about it, we're going to go from left of the screen to the right. So on the left, you see that the transducer emits an ultrasound beam, which goes and hits your visceral pleura. Both parietal and visceral pleura are strongly reflective surfaces. What that means is almost everything that hits these structures reflects back. So as the sound waves come back to the visceral pleura, it reflects back. However, because parietal pleura is also a strong reflector, some of it bounces from the visceral pleura back towards, or excuse me, bounces from the parietal pleura towards the visceral pleura. So there is this back and forth bouncing. However, each time there is this bouncing, there is also some amount of ultrasound beam that goes back to the probe. Each time there is something that goes back to the probe, it creates a hyperechoic white line, and the subsequent ones are all going to be parallel, but they are going to be further and further from the first line. This leads to what is known as a comet tail artifact, where there is a bunch of parallel lines. This can be seen in lung ultrasound. It can also be seen when you are looking at a needle using ultrasound inside the skin in a longitudinal plane. Sometimes people also call is the ring down effect or artifact as well. This artifact leads to creation of what are known as A lines, which we will look at in the next slide. So A lines, these are the normal lung artifacts. This image here, the black lines show shadowing from the ribs. The gray structure in the center is the lung parenchyma, and the bright white lines are, the first one is the pleural line, but the rest of these parallel lines are the reverberation artifact, which are known as A lines. Again, this is normal lung finding, but it can also be seen in diseases where there is just air inside the lung. So an example of that may be asthma or COPD. So let's see what this looks like under the ultrasound. So here you see an ultrasound image. On the top of the screen you see the pleura, and then there are these multiple parallel white lines. These are known as your A lines. The next artifact is called as B lines, or sometimes as the lung rocket. So B lines are formed whenever this continuity of air is broken by presence of either fluid or by presence of consolidation in the lung. And so in that case, what happens is, instead of the sound waves bouncing back and forth, they are able to transmit down all the way to the bottom of the screen and form these vertical lines, which are now known as the B lines or the lung rockets. The way that I think about the B lines are that B lines can be isolated. That means you're seeing either one or two B lines per area of the lung that you're scanning. This can be normal and physiological, and if I don't see more B lines in other areas, I'm not that worried that this is something abnormal. Multiple B lines can be either confluent or they could be well delineated or separated. When these are well separated and there are more than two per lung zone, this is considered abnormal. And based on how many lines are there and which parts of the lung are they in, I can come up with a pattern that illustrates a disease. For example, let's say a patient has pneumonia of the right upper lobe. We know that this is a focal disease that is only restricted to one part of the lung. And so if I was using ultrasound to look for B lines, where would I see B lines? You're right, you would only see those in the right upper lobe, while the rest of the areas of the lungs would be relatively spared. So that's just one way to think about this. And finally, there are confluent B lines, which are B lines that are so dense and clumped together that it's impossible to make them out as separate. And these are always pathological when you see them. So if you're scanning the lungs and you see an area of confluent B lines, that's an area worth exploring more. So go back and scan some more till you get better images of that particular area. Now, here is an example of what well-demarcated B lines look like. Um, let's see. This is an example of confluent B lines where you can see that the lines are so close together that they seem like one giant waterfall of sound waves rather than individual or distinct B lines. And like I said, these are always pathological. The last artifact that I want to talk about are what are called as the Z lines or the lung comets. These are also a normal artifact. They emerge from the pleural line, but the difference between B lines and Z lines is that Z lines, they do not travel to the bottom of the screen. They move with pleural sliding, and they are formed due to the physiological amount of free fluid in between pleura, and again, this is normal. So here is a still image of what this looks like. You can see the bright white hyperechoic line, which is the pleura, and then the arrows point to these vertical artifacts, which are known as the Z lines. So at this point, if you're listening to the video, I would take a second to pause, go back and review the artifacts that we talked about if you need to, and then right after that we will jump into diagnosing some pathologies and how to practically apply lung ultrasound to the bedside. So the first pathology that I want to talk about is diagnosis of a pneumothorax, right? What is the right setting to do this? You have a patient who is either on a ventilator or has been in a trauma or has some other reason, such as a child with Marfan's who presents in respiratory distress, and you're trying to see if the child may have a pneumothorax or not. So ultrasound is great for that. The artifact that you are looking for is known as pleural sliding. And so let's look at this first picture on the left here. You see an ultrasound image from the top of the screen to the bottom is the skin, the muscle, the subcutaneous tissue, the ribs on either side, and then this bright white line, which is the pleura. You can see that the pleura seems to be moving side to side. Some people have described it as ants marching on a log or shimmering of the pleura. Either way, you can see the movement of the pleura, and this is normal. Moving on to the image to the right, it's a little bit harder to see and you do not appreciate any movement, but if you were to pay close attention, you could appreciate some movements from breathing of the patient at the area of the muscles and the subcutaneous tissue. However, the pleura does not seem to move at all, and this is known as absent pleural sliding. The big question is all absent pleural sliding pneumothorax? The answer is no. Absent pleural sliding may be pneumothorax, but it could also be some other things. What are these other things? It could be absent with dense atelectasis or dense consolidation from a lobar pneumonia. Sometimes you can see it with a pleural contusion. Sometimes it can be seen with prior pneumonectomy or where the pleura may be stitched. And then lastly, one other thing that I didn't mention quite on the slide is if a patient were to get right main stemmed, then on the left side, pleural sliding may be absent. However, you may be able to see either Z lines or B lines, which suggests that there is no pneumothorax there. So is there anything that's more confirmatory than pleural sliding? There is. This is known as the lung point. What is lung point? Conceptually, if you pay attention to the CT scan image here, you see this area in the anterior part of the chest where there is some air collected. In the back is the lung that is probably a little collapsed. And look at where the arrow is pointing to. The arrow is pointing to the lung point, which is a transition area between the pneumothorax and the lung. This is exactly what we see in the clip here, where you can see a part of the pleura that is sliding, which is the area of normal lung, and then this part of the pleura that's not moving at all, which is where the boundary of the pneumothorax is. This is confirmatory for pneumothorax. If you see this, and if your patient is decompensating, I would feel pretty comfortable putting in a chest tube to address that. Moving on, our second simple lung ultrasound criteria is a pleural effusion. Pleural effusion could be either a simple effusion or it could be a complex effusion. So the first image on the left is a simple effusion. Here in this image, you can see that the probe is placed in the right upper quadrant area. Here you can see the liver, the kidney hiding behind the liver here. There is the diaphragm, and then there is this large collection of anechoic fluid or black fluid, which represents a simple effusion. You can also see that the spine, which normally terminates where the diaphragm is instead in this picture going all the way to the edge of the screen, and this is known as the spine sign. In cases of small effusions, when you may not see the fluid directly, this can be a very useful sign of diagnosing an effusion. The picture on the right shows what's known as a complex effusion, where you can see that there is fibrin stranding that is floating inside the fluid. Some people have described this as the jellyfish sign or the plankton sign. When you figure this out or when you see this, it is important to pay attention to this, because this is not a patient that placing one chest tube is going to drain all of the fluid. Rather, it is a fluid collection that may require additional interventions. So pay attention to that. And pleural effusion is the gold standard for diagnosing ultrasound is the gold standard for diagnosing pleural effusion. CT scan may be slightly better, but the difference in the amount of fluid is just so trivial that I don't think it's ever clinically useful, even if I see some amount of pleural effusion on the CT scan, but I don't see it on the ultrasound. So this is definitely my go-to way of diagnosing a pleural effusion. So some points to finish this section off. A simple effusion is black in color. It's anechoic. You can see spine sign with effusion, whether simple or complex. Complex effusion, fluid is seen with fibrin stranding inside. There may be cavities or septation. This is known as the plankton sign or jellyfish sign. The third diagnosis that I want to talk to you about is pneumonia. And it is such an important one for pediatrics because the literature has suggested that ultrasound is just way better at diagnosing pneumonia than a chest x-ray, which underdiagnoses it all the time. So a lot of times you can diagnose pneumonia by just physical exam or by using an x-ray. So what is the role of ultrasound? So these are 4 or 5 reasons which I think ultrasound may be helpful in. So it is definitely faster, safer, and better at diagnosing. When I see a lung x-ray where the lung is whited out, it's harder for me to differentiate between effusion and pneumonia when signs such as shifting of mediastinum or collapse of ribs are not clearly seen. When on the x-ray it's not obvious that the patient has pneumonia, but the clinical history is pretty rich in suggesting that it is a pneumonia. When I'm trying to figure out the evolution of the disease or assess response to therapy, that is when I reach for my ultrasound to get more information. So here are the 5 main diagnostic criteria for pneumonia on the ultrasound. These are hepatization of the lung, where the lung starts looking like the liver, a subpleural consolidation that is less than greater than a centimeter. When you see confluent B lines in a single lung zone with pleural irregularity, when you see what's known as the shred sign, and lastly, a dynamic air bronchogram. So let's start with this first picture that I'm going to play for you all. So here are a few different signs that you see in this picture. So the first thing I want to point out to is what's known as a hepatized lung. So if you pay close attention to this image, at least the top portion of the skin looks like a dense tissue, which is very similar to the appearance of the liver. The next thing I want to point out are the dynamic air bronchograms, which is you see in this orange circle an air bronchogram that moves up and down. And then along the rest of it, you see static air bronchograms, which are all these areas of bright white spots within the lung tissue. This looks almost like a starry sky appearance. And so these are all signs of a pneumonia. Moving on to our next picture, here again you see in this top portion of the screen, you see tissue that looks very different from the rest of the lung architecture, and it looks like a liver-like consistency. You see shred sign, which is basically just these irregular margins that are formed around the area of consolidation. And then just below this, you see a ton of confluent B lines. And all of these together are very strongly suggestive of a pneumonia. You can also call this area of hepatized lung as a subpleural consolidation. Essentially what that means is subpleural is below the pleura, and consolidation is an area of lung that starts looking in a different consistency than the surrounding lung tissue. Okay, moving on to diagnosis number 4, which is pulmonary edema. So for diagnosis of pulmonary edema, what you require is the symmetrical presence of B line in all areas of the lungs, right? Because if we think about it carefully, whenever there is fluid in all areas of the lung, it's almost never in just one part of the lung. It will be symmetrical in distribution all over. So here's a little case vignette for you, which may help you think through what kind of a patient might this be helpful for. So a 15-year-old patient with Duchenne's muscular dystrophy and dilated cardiomyopathy presents to the ED in shock and with increased respiratory requirement. The patient is cool and clammy on the exam, and the lactate is elevated. So what's my differential diagnosis here? Is it worsening cardiomyopathy? Does this patient have sepsis? Is this fluid overload or pulmonary edema? And is this or pneumonia? So this is the kind of differential diagnosis that I can think about and sort using a lung ultrasound. So let's look at what that picture looks like. So here's the picture of what you may see in pulmonary edema, where you see B lines that are well demarcated. They are present at equal distance from each other. And so this is sometimes very helpful in diagnosing pulmonary edema. So while it's great to look at all these different diagnoses one after the other, I also think that generally when we are examining the lungs or any other organ system, we don't always have a diagnosis in mind. Sometimes we are getting through our physical exam, we're getting through the history, and we're trying to figure out what can the diagnosis be. So in that case, thinking through one particular diagnosis at a time is not helpful. Putting it all together is helpful. So this is exactly what I want to do. I do want to apologize about this messy scribbling, because instead of putting it together on a presentation, I thought it would be much more helpful for me to write my thought process on a piece of paper. This has been described in the literature known as the Blue Protocol, and I've tried to simplify the Blue Protocol in my own way. So in the beginning, when I'm looking through my pictures, what I try to do is I try to scan all areas of the lung systematically. and put them together, look at them carefully. And then I start from the top where I see, does the patient have lung sliding? If the lung sliding is absent, I look for what else do I see on the ultrasound. If all I see are A lines, I next try to look for a lung point. When I found one, it is suspicious for a pneumothorax. If the lung sliding is absent, but there are B lines, there is abnormal pleura, or there are air bronchograms, or any other signs of pneumonia, then this is concerning for a dense pneumonia or a lung contusion or whatever the patient's clinical history suggests. On the flip side, when the lung sliding is present and I see B lines that are present in all lung zones, that is consistent with pulmonary edema. When only A lines are present with lung sliding and the patient is desaturated, I try to look at the femoral veins for a deep venous thrombosis. If there is a deep venous thrombosis, then I get real concerned about pulmonary embolism. If there is no DVT, which means I have normal lung sliding, normal feature, A lines present throughout, also a normal finding, but the patient is desaturated, I have to think about either is it asthma or if it's older patient, it's COPD. And finally, if there is a mix and match of all these different findings, then that leads to a little bit more advanced criteria of diagnosis, which is COVID, ARDS, or bronchiolitis. And then finally, I want to wrap up with two diagnoses that are not very pertinent to my practice, but is very useful for my neonatology friends. And if you take care of neonates, these may be very helpful. So the first one is respiratory distress syndrome. And as we understand it, respiratory distress syndrome is generally a disease of prematurity where the lungs are not mature enough to produce adequate amount of surfactant, and it leads to a child having breathing difficulty. So what do I expect to see in a patient with respiratory distress syndrome under lung ultrasound? Here are a few different things. So because it is a disease that is asymmetrical, you will see signs that are bilateral, but maybe a little bit more predominant in one part of the lung than in the other. You would see thickening and irregularity of pleural line, plus subpleural consolidation and widespread confluent B lines. There will be just B lines everywhere. So let's look through some pictures which help us with that. So the first picture that I have for you is that of a thickened and irregular pleura. As you can see, in the first part of the clip, you see nice fine pleura. And then in the later part, you see this jagged, rough, crusty looking pleura, which is your thickened and irregular pleura. The next image I have for you is a still image. It is not my picture. It is from one of the research papers that I've taken this. And I want you to pay attention to a few different things. Notice how the pleura is irregular. It is jagged and broken down. There is a small subpleural consolidation right here. And then you see these confluent B lines that to me look like a waterfall of B lines. And so when I see this and put this all together, for me, this is respiratory distress syndrome. And then the last one is the transient tachypnea of newborn, which is a disease of a child where there may be some lung water present after birth and gets better in a few hours to a couple of days. So here's the diagnostic criteria on the ultrasound. What you see is a double lung point and numerous well-demarcated B lines. Pleural irregularity may or may not be present. So let's see what this double lung point is. So a double lung point is an area where you see pleural sliding with A lines and normal lung architecture. And then you see another area adjacent to it where you see pleural sliding, but now with these dense B lines that are well demarcated. So please pay close attention to the fact that in double lung point, you actually have lung sliding in both areas. So the terminology is a little bit misleading, but what you see makes a lot of sense. It is an area of the lung where the fluid has already disappeared next to an area of lung where the fluid is yet to disappear. So pay close attention when you're diagnosing this. And then lastly, some of the other indications, like I said in the beginning, this is not a presentation that covers about everything. It covers the simple and the intermediate complexity things like pleural sliding, pneumothorax effusion, etc. Start with those in your practice and learn advanced things after that. I want to close this presentation by my advice about premature closure. A lot of times when I started doing ultrasound early, I was a hammer looking for a nail. What that means is I went in to the ultrasound exam thinking in my head that this is what I'm going to find, and that's exactly what happened. I found whatever I was looking for. But that led me to do errors, and I want you all to avoid that by looking beyond the obvious and avoiding premature closure. So that'd be my advice as you learn more and more of point of care ultrasound. Again, I want to thank you all for listening to the lecture and for the group for giving me an opportunity. Here are my details on how you can reach me, and I would be more than happy to answer any questions or look at some of your images that you take on your own and want feedback on. Take care, guys. Bye-bye.